Hello, my name is Mohamed Elnagar. I work as a gastroenterology teaching fellow. Thank you for giving me this opportunity on behalf of the liver team at Royal Derby Hospital to present our experience in using long-term abdominal drains in refractory ascites. You are all familiar with the causes of ascites. Ascites complicate cirrhosis in 50% of patients after 10 years. Unfortunately, up to 10% of them will suffer from refractory ascites. Refractory ascites is associated with a poor prognosis with 50% mortality after 1 year. It can only be cured by liver transplantation, but other options to control refractory ascites include TIPS, large volume paracentesis, long-term abdominal drain. We retrospectively reviewed all patients treated with long-term abdominal drains between 2009 and 2019. All the patients were reviewed for indication, frequency of large volume paracentesis, duration of hospital stay, reported infection 6 months before and after, other complications, duration of the drain. All drains were inserted by experienced radiologists in 24 patients with average age of 68, and at the time of insertion, median mean score was 14. The majority of the patients had NASH and alcohol-related liver disease, but we had a couple of patients who suffered from cardiac failure or cardiac cirrhosis. Drain insertion successfully reduced the need for large volume paracentesis from a median of 5 before down to 0 after the insertion. Hospital days were down to a median of 12 days after the insertion from 19 prior to insertion. Drain lasted for a median of 67 days with the longest duration of 465 days. Unfortunately, SBP remained the main complication we faced in this group of patients. 7 patients had been treated for SBP before the insertion, of whom 6 were taking prophylaxis. Following the drain insertions, 15 patients were diagnosed and treated for new episodes of SBP after a median of 60 days. Treatment was with at least 10 days of antibiotics, and 10 patients needed drain removal while 4 had a replacement. Sadly, 5 patients were reported to die from infection. So to conclude, infection was the main complication following the drain insertion. There was marked reduction in the need for hospitalization despite the infection. Also, there was marked reduction in the frequency of large volume paracentesis following the drain insertion. There was no direct relation between MELD score and longevity of the drain. We recommend that careful and early assessment of these patients may be helpful in timing of the insertion, and the use of antibiotic prophylaxis, which we already started to practice, may reduce the burden of infection following the drain insertion. Thank you.